All right, we'll give it just a couple of minutes and then we'll get started. We've already got people joining, so thank you for joining us tonight. Welcome to the first webinar of 2022. It's hard to believe we're saying that already, but really appreciate the audience joining us tonight. We're excited to have Dr. Randall Duthler, the Chief Medical Officer from ADHD Online, here with us. We'll give it like one more minute and then we'll get started. We did want to let the audience know I'm Keith Boswell. I go by Boz. I'm the VP of Marketing here at ADHD Online, and we're very excited about these webinars and conducting many more of them this year. We are really trying to set the bar for being a resource for ADHD and the ADHD community. And so we wanted to kick off this new year with kind of an open forum, and we appreciate everyone that took the time to submit questions in advance. We'll try to get through all of those. We're also going to be taking live questions that we'll ask Dr. Duthler, and then this recording will be available afterwards. And so would encourage you, if you find it valuable, to share it with others as well. So we'll go ahead and get started. Dr. Duthler, Randy, I'm privileged to call you. Thanks for joining us tonight. I'll just go ahead and let you get started.
Thanks for the introduction, Boz. Yeah, so as you're seeing here on the screen, I'm a doctor, but I'm not your doctor. And so don't want to have this construed as medical advice. Always consult your doctor before making any medication changes or changes to your regimen. But, we are really excited to see just the response to the invitation to have this webinar. And we feel so passionately about this topic and are very pleased that all of you are willing to open up a dialogue. And I think education is just such an important thing that we focus on at ADHD Online, because I think patients that really understand what ADHD is, how their medications work, and how they can harness ADHD for their benefit, those patients really do better overall. And as far as kids go, if you're viewing this with children, and a topic comes up that I think is going to be sensitive, I'm a dad as well. I will certainly give you just a quick moment for those little ears to step out. If you have kids in the house and you think that you'd like to have them join the webinar, I think that's fantastic, because I think it's never too early to start teaching kids to advocate for their healthcare and ask questions about their conditions. And so we certainly welcome their questions and welcome them to join us as well. So so we'll step right in here.
Great. Well, Randy, I can give you the first question. So we had a question come in that was about seeking the clarification of the differences in symptom presentation or manifestation in boys and girls in their early years, and what factors tend to trigger seeking help or diagnosis later in life.
Absolutely. And you might want to just discontinue the screen share so we can have a clear view here. But we recently did a campaign about female patients with ADHD, because many times they were diagnosed or misdiagnosed as just anxiety. And so the presentation can be different in boys and girls. And it's really important that we keep track of some of those things. Even as we age from childhood through the teen years, all the way through the adult years, the symptomology can actually change, particularly when it comes to the hyperactivity component. So, the inattentive component, that stays fairly standard. So that's, the daydreaming, it's the half listening. Sometimes it's an issue as far as when patients are reading. So sometimes they have poor reading comprehension because they drift off in their mind halfway through. So that's pretty classic across most of the age groups. But as far as hyperactivity goes, that is very, very different. So in boys, they're often described as driven by a motor. And I can tell you that is a perfect description of hyperactivity, because it's from start to go, from awakening to bedtime, just very, very busy all the time. Now, in girls and in adults, it can be a little bit different. So it can be as subtle as missing social cues, like intrusion into conversations. It can be a general sense of just being impatient, like listening only when to know when to respond, a cue to respond. It can be just frustration with waiting. It can be fidgeting and those kinds of things. But very commonly in girls, it is this sense of anxiety that presents alongside this. Now, where you really get kind of stuck here is oftentimes ADHD can present alongside anxiety or depression. And so that's where it really takes kind of a trained eye to look at what we call the primary feature when we're treating patients. What is the primary issue? And you don't want to pull too many levers at once when you're treating. So, if we think the primary issue is ADHD, we'll start there. If we feel like the primary feature is anxiety, we may start there. But I think a lot of other providers do the same thing. And where our female patients make it to us is usually that primary feature of anxiety has been treated over maybe even too long a period of time, and multiple things have been tried and failed, and then there it is underlying ADHD. You give the medication for it, and an immediate improvement. So very different presentation across different patients demographics.
Great. Let's see. We just had a question come in to the chat. I read that, this is from W. Austin Reeves. I read that a large majority of kids with ADHD have low iron levels. Is that the same for adults?
So iron levels, yeah, that's something that has come up multiple times. And so, some patients will describe chronic fatigue associated with iron deficiency. The classic one we hear about is, feeling cold all the time. That and thyroid dysfunction is feeling cold. But it can also present as general fatigue. And that, of course, can affect attention. Now, low ferritin levels are also associated with restless leg syndrome. And that can oftentimes mimic the fidgeting that is associated with ADHD. It's a little bit different, though, because with ADHD, the fidgeting is often associated with boredom and sometimes times of stress. It's more predictable, whereas restless leg tends to be just intermittent throughout the day. And in the evenings, it tends to present far more strongly than what we would see with hyperactivity.
Great. We had another question come in from the chat asking about, from Michael Emery, tips for putting kids to bed with ADHD.
Oh, I love this question. The answer is routine, routine, and routine. So, the longer the bedtime routine, the more structured the bedtime routine, the better the kids do. So, many of you, may find yourselves able to wake up without the use of an alarm. You just wake up at a certain time every day. And that's because, your body, you've kind of trained yourself to do that. There's a term we use in medicine called sleep hygiene. And it really speaks to our bedtime routine and what we do to make bedtime more predictable and more consistent. And so, usually setting a bedtime, sticking to it as best you can, turning down the lights down, an hour before, not watching, super stimulating things prior to bedtime. And then melatonin can be helpful as well. But, those steps along the way, it also depends on the age too. So the younger kids, we're talking like bath and snack and then, story and then bedtime and lights out. For older kids, sometimes it's slightly less regimented, but also with older kids, we really want to make sure that we're not spending a lot of time reading in bed, on tablets, social media, video games in bed. That is a major issue with sleep hygiene in general, but particularly with our ADHD patients. And I don't know how many of you are on TikTok, but you can go down a rabbit hole really fast, and teenagers are especially vulnerable to that. And so that's why, one of the biggest things in getting kids to bed with ADHD is just getting that technology and stuff out of the bedroom and setting that more regimented bedtime.
I think all of us could probably benefit from that, honestly.
Yeah.
We got another question from Rebecca. I'm a 60-year-old woman who was just diagnosed. Is there any medication that's better for older patients?
Well, we would probably look at non-stimulants first. It depends largely on your history. So if you had a history of, heart disease, or you had a history of hypertension or other things, stimulants may not be quite as safe as other medications. We would also look at what the primary feature was as well. If it was inattention, if it was hyperactivity, we would look to see if there was any comorbid conditions such as, social anxiety, Sometimes we'll switch to a drug like just Inderal, which is off-label for ADHD. Wellbutrin is one we use sometimes if we have some mild ADHD associated with some depression or agitation. If it's just straight inattention, sometimes Strattera is a better option. It's not that stimulants are contraindicated. I think patients of any age can benefit from these medications. It does, require someone with a bit of an expertise to understand the dosing schedule and how to dose those. One other, factor as we start to age is, just naturally, kidney function can decline a little bit. How we metabolize drugs changes, and so having someone who's really knowledgeable around what we call pharmacokinetics, which is, how drugs are metabolized, broken down, and even absorbed from the beginning, that makes a big difference in deciding on a safe and effective regimen. So, yeah, I think I would start, as you prepare for your visit with your doctor, take a minute to write down just a lot of the issues you're having as far as, is it depression? Is it anxiety? Is it agitation? What are the primary features that you're dealing with? What are some of the social areas that are impacted? And then really, what are your goals? And you should be able to formulate a pretty good plan if you have all that together at the time of the visit.
Great. All right. Well, I'm going to switch back to one of the questions that we got in advance. This one's from Dylan. What's the best approach to managing adult ADHD symptoms other than medication? And how does caffeine affect adult ADHD?
That's a great question. I always kind of chuckle when I'm in line at the gas station. I see somebody with 4 or 5 Monster drinks in their hand. I almost want to hand them my card and tell them to come see me. I think people with ADHD are drawn to sugar. We're drawn to caffeine. Caffeine is a stimulant. And so many patients will self-medicate in those ways. I've even had patients, who admit to taking harder drugs like cocaine, just to try to self-medicate. What can you do naturally? The first thing I would say around that is, if you choose to do that and avoid medication, do that, just because you feel supported and that's what you want to do, but not because of any kind of negative connotation associated with taking medication for ADHD. I really think it's important we break through those barriers. And I always tell my patients that, you would never apologize for having diabetes. You would never tell someone with diabetes that if they just made more insulin, things would be better. And then in the same way, we shouldn't be doing that with mental health. But if you decide to make that decision, there are some supplements that are out there. Brillia is one. None of these are regulated very well. And to be honest, we don't really even know what the active ingredient is in them. So from a safety perspective, it makes us a little bit nervous. I think sometimes some of these companies stamp all natural on a bottle, and that, sometimes elicits some feelings of safety. But, I remind patients that, mercury and cyanide are all natural also, and we wouldn't consume those. So just, a word of caution with that. I think healthy diet makes a huge, huge difference as well. So, tell people, as a general rule, shop in the periphery of the store. The processed food, the junk food plays a negative role in symptom control. Exercise, particularly in adults, is tremendously important for stress levels and also just helping with ADHD. The other thing you can do is you can work with a couple of different coaches. So it depends on what your role is, what you do for a living, but maybe learning how to take notes really well, or working with an organizational specialist or someone like that to help you get things in order, leveraging people that are close to you if you're comfortable, disclosing the diagnosis and saying, hey, I do better with lists, or hey, I need some reminders. Those things are helpful as well. But at the end of the day, what I have found, my experience has been that ADHD tends in the adult years to rear its head over and over, from promotions, that professional exam you have to take, whatever it is, it rears its head. And I encourage patients to feel comfortable treating for just a short period of time. If you have a 2-week orientation period and you want to be treated for 2 weeks, that's fine. I have a contractor who works, he swings a hammer every day of the week except Friday morning. He takes one immediate release pill Friday morning for 4 hours, and he does his paperwork and he's done. So there's a lot of ways to tailor this, and it doesn't necessarily require being medicated every single day. So I hope that answered your question.
I think it does. And Dylan had one other question that feels somewhat related, and that's, is there any use in looking into possible thyroid issues before getting an ADHD diagnosis?
That is part of our assessment process, actually, is to look for some organic conditions that can mimic ADHD. So we're looking for diabetes, we're looking for thyroid dysfunction, iron deficiency was mentioned already. We're looking for obstructive sleep apnea issues. We're looking for issues with, lack of exercise. We're looking for many comorbid conditions that can affect attention and cause also some symptoms of um, of hyperactivity or affect executive function. So absolutely, that's worth screening for.
Great. Let's see. Let me go back to the chat. What question from Tiffany? What is the gold standard treatment for a woman who's been newly diagnosed?
I don't know that there is necessarily a gold standard. As much as we don't like it, insurance companies have a larger role in our decisions than we'd like. Just because they control cost. What I do is I usually will start with a patient. I'll ask them, what does your schedule look like? Are you an 8 to 5 kind of person? Are you a college student that has a really crazy schedule? I look to see whether or not we need a continuous steady state drug, like a non-stimulant. That would be your Strateras or your Wellbutrins or a drug like that. Or if we just need it 8 to 5 and then it's off during the day, or maybe we want to be off during the weekends. Once we've made that decision, let's start with stimulants. I will usually start with a methylphenidate-based drug, and those are your Concertas, your Focalins, your Ritalin LAs. They're all methylphenidate-based. These were started actually in the 50s with just regular immediate release Ritalin. Over the years, what has made each of these their own little proprietary formulation is they take a very common drug and figure out how to dissolve that in salts slowly over time. It's the extended release capabilities of the drug that make them proprietary. But the actual drug itself, the active ingredient that's working, has been out since the 50s. So that's usually what I start with. One thing that does kind of move the needle a little bit here is family history. And we sometimes will do gene site testing on patients that have failed multiple treatment options. And it really proves what we've known all along. That is, there's a genetic component to this, and not every patient responds the same way to every drug. So if I have a patient that comes in and says, all of my brothers or all my sisters have tried methylphenidate and it fails, they're all doing fantastic on Vyvanse, or they're all doing fantastic on Adderall, I'll probably start there. And then, the last component, again, we don't like to use this as much as just cost. So we want to be mindful of patients' issues with cost.
Right. That makes sense. So, well, kind of related to medications, we had a couple of questions come in from the Q&A. One is from someone who asked, why does the Adderall 30 milligram extended release make me feel depressed and low mood around dinner time and throughout the evening versus Adderall 30 milligram tablets? Is there a difference in why this happens?
These are great questions. Yes, this has to do with the pharmacokinetics and how the drug actually dissolves and throughout the day. So you may be someone who metabolizes the drug very differently, and you may have what we call a cliff. And so sometimes people will metabolize very slowly throughout the day, and then all of a sudden they get to the end and there's this cliff, and the active drug in their bloodstream drops precipitously. And you may notice that you feel just kind of down and blah. Even sometimes agitation can be something we see. If your blood level drops off very quickly, you may see some agitation associated with that, and feeling a little bit bluesy. Adderall in particular is one we even use for hospice patients. So, if a patient has a very short time to live, a week or 2 weeks, sometimes we will use Adderall, and we use it as almost a form of an antidepressant because it works almost immediately, and it has that mood elevation associated with that. So naturally, if it elevates when it goes up, it's going to make you feel sometimes a little bluesy as you come down. But this is where we really leverage a symptom diary. And so what I have my patients do is I have a map out by the hour when they start to feel that crash. And sometimes what we'll do is we'll decrease the dose a little bit, maybe like to 20 milligrams, and we'll add in just an immediate release in the evenings and see if that helps. Sometimes we'll switch to a different type of drug, like just immediate release, twice daily dosing, to see if we can avoid that cliff and make it just a little bit smoother drop off in the evenings. But that is a common side effect, and it absolutely is manageable.
Great. So kind of a follow-on question that Abigail had, does the use of stimulants long-term increase the risk of cardiovascular problems or disease?
No, there's been no evidence that it increases cardiovascular disease. Interestingly, though, stress can do it. And so patients with uncontrolled ADHD sometimes will have, more stress and more anxiety. I think that that definitely plays a role in cardiovascular health and health in general. But, again, these stimulants have been out since the 50s. They're very well studied. And even in older patients, I have really no concerns prescribing these for patients. And I really don't see any risk long-term from a cardiovascular standpoint.
Great. All right. So let's see. From the chat, from Kristen, my teenage daughter is on medication for anxiety and depression. I suspect she has ADHD. Can she take medication for both?
Yes, you can. So we commonly use these medications together. I would tell you, when you do the assessment, make sure that you don't change anything. So if she's stable on a current medication for anxiety, go ahead and continue that during the assessment process. You don't want to start pulling too many levers at once. And then we can absolutely treat alongside anxiety and depression. And again, it would be really great if there was some really, smoking gun test. That's what we all want in medicine, right? This yes or no, like a pregnancy test, just to tell us exactly. But that's not how it is in mental health. And so oftentimes, it takes treating to be able to find out what the right regimen is going to be. So, if a teenager has an issue with inattention and also the anxiety, I'll go ahead and I'll treat the ADHD. And then sometimes I'll peel away the layers of the onion and I'll say, so, okay, you reeled your inattention in, school's doing great. You're, doing fantastic with that. How's your anxiety level doing? And if I see that dropping, I'll start to then peel away that dose of the anxiety medications. What's really interesting with ADHD, anxiety, and depression in teenagers is when we find that secret sauce, just the right regimen, that makes counseling so much more productive. And when we can get kids engaged in counseling and we can get them to understand the mechanism of the anxiety and some of those defense mechanisms to handle the anxiety, that really, really makes a big difference. And you can also check back later because we're going to be having some webinars with nutritionists talking about that, teachers teaching how to do note writing, and some psychologists talking about anxiety and how you can manage that with just the chaos that ensues with ADHD. So that's a long-winded way of saying I absolutely support testing in a child where you even suspect ADHD.
Great. All right, we got another question from Dara in the Q&A. My therapist is having a hard time diagnosing me because of all the very early childhood trauma. I'm 51 years old, but my trauma happened as a very young child. How can you tell the difference between trauma and ADHD? My brain never seems to stop, but she said it could come from a lack of coping skills and it's just anxiety. Please clarify how to tell the difference.
Great question. And thanks for bringing that question up. That is, I think, tremendously hard to even talk about and acknowledge. And I think that surfaces some feelings every time you bring it up. So thanks for having the courage to bring that topic up. I think that sometimes, again, we're looking for that one thing, and there isn't always one thing. Sometimes there's multiple things. And one thing I tell my students, I do a lot of teaching, is never wear blinders in medicine. Always keep digging for something else that could be involved. So, what I would start to do is look back to early childhood. That would be my starting point, because ADHD is not something we acquire as adults. It's there even in early childhood. So I don't know at what age your, traumatic events occurred, but, if prior to those events, you remember teachers saying that you're disorganized, that you need to pay attention more, if you remember being reprimanded for that, then that would certainly raise an eyebrow for ADHD. And I think it's also important to recognize that, years ago, ADHD just wasn't a thing, right? I mean, so nobody talked about it. It was just study harder and, yell at the kids if they didn't do well. So it may not have been on the radar, but, oftentimes if I dig a little, patients will remember some of those childhood events. The other thing is I would look at how well your anxiety and your PTSD symptoms are being managed. If every drug you try fails, then that may indicate that you're not on the right regimen. And I would look specifically to triggers. Some triggers will be more related to PTSD, sight, sound, smells, events, those kinds of things that will, re-trigger some of those past traumatic experiences that you had. Whereas predominantly inattentive issues will be running late all the time, chaos in your world because everything's disorganized and scattered and things like that. Those are usually the things that bring up anxiety from an ADHD standpoint. Where it can get a little difficult is if you have multiple legitimate sources of anxiety, ADHD over here, PTSD over here, other things, it can be coming at you from all angles. In that case, you really sometimes just have to treat. And I have no issue with that. I have had some assessments come back as what we call equivocal, where the psychologist will say there's just too much muddy water here. I can't say for sure. And in those cases, I am comfortable saying, let's go ahead and treat and see what happens. And patients usually within 1 to 2 weeks, you're going to either see a light switch and they're going to know, or it's going to flop and you can pretty comfortably exclude that as a cause.
That's really helpful. Thanks for answering our question. Let's see. Let's go to another one from the chat. What do you do? This is from Kirsten. What do you do if you lose your meds just after you pick them up from the pharmacy?
That's a problem. Most doctors will go ahead and refill those medications, on a case-by-case basis. They don't want to do it all the time, but, of course, we're all human and, most of us here have ADHD. So, we recognize that happens. We would be concerned if we saw a pattern. A lot of patients go through the bother of getting a police report. I'm not sure that's necessary because the police don't do anything other than just paperwork. So I'm not sure that's any value. One snag you can run into is insurance coverage. So the insurance will pay for a 30-day supply. You may be on the hook for that medication if you get it refilled early. You should know that there is a report that's run. It's a government report, PDMP report, and it tracks several things. It looks at who prescribed your drug, what it is, what the dose is, how much they gave you, when it was written, when it was filled, and how you paid for it, and what pharmacy you went to. A lot of information there. And so there is a risk score that goes alongside of stimulants and opiates and benzodiazepines. And so you should know that if you develop a pattern of early refills or replacing lost scripts, that'll raise that score. It's almost like a credit score for controlled substances. So if you were to go and have surgery, or you would go to the hospital for another reason, they pull this PDMP report, that just, you may have some explaining to do if that's the case. Alongside this, I'll tell you one other thing. One thing that sometimes patients do is they don't want to run the risk of losing their whole script. So what they'll do is they'll take a little bit and they'll put it in these little pill bottles. I've seen these little keychain things, the silver ones on there. And I would really caution people not to use those. The reason is if you had several of those in one of those containers and you were challenged by the police, you could be accused of distribution. And so what I tell my patients to do is keep your first pill bottle and make sure it always has your name on it and my name on it. And then rather than throwing that out after you get your next refill, if you're going to transport 2 or 3 pills, put it in that and take it with you. It's safer. You won't lose the whole batch and you won't be accused of distribution.
Got it. Right, well, I'm going to go back to one of the questions we had submitted before the event. This one's from Quentin. What's the difference between ADHD and ADD? And is it possible to get ADHD as you get older? He also asked, what can the online doctor do? They often throw depression pills at me because I wear myself down. Then I have no energy for the other half of the day. Does depression share some of the same symptoms?
These are great questions as well. So the term ADD has been retired, and I don't think it's been well publicized. And many patients come to us and think we can't help them because they don't have hyperactivity, so the ADHD doesn't apply to them. And that's absolutely not true. So now we use the terms ADHD inattentive, ADHD hyperactive, and ADHD combined. Those are the 3 predominant diagnoses. There are other ones out there like adult residual or unspecified, but the top 3 are the inattentive, hyperactive, and combined. As far as can symptoms manifest as adult, ADHD is present during childhood, but what's interesting is that different features can rear their heads at different times of life. And in adult years, the hyperactivity changes drastically compared to during childhood. So, this is the person where, you're at the movie theater, someone's talking behind you, they bring up a topic you're interested in, and all of a sudden now you're intruding into their conversation and talking about that, or, you're interrupting, or you're having difficulty, waiting your turn. is really hard sometimes. That is all a hyperactive component of ADHD. As far as depression goes, we should break that down just a smidge here, because depression can be just, feeling down and feeling bluesy and feeling sad. There's a subset diagnosis of agitated depression that we like to focus on as well. It's important that we look at that, because some patients with ADHD have a difficult time with hearing criticism, even positive criticism, or have difficulty with rejection. That can be a really visceral response, and they can kind of fly off the deep end. So we always try to figure out, okay, is this truly like a hyperactive impulsivity component here, or is this a agitated depression that's hiding in the background? The other thing is just, I would just call natural human behavior. So, if your world's in chaos, maybe you're being skipped for promotions, or you feel like you're not effective at work, or, you're feeling frustrated. I think it's completely natural. You're going to feel a little bluesy, a little depressed with that. And so sometimes we'll start with the ADHD and see what happens with the depression. And if it resolves, then great. And if it doesn't, sometimes we'll tackle the depression as a subset with a different medication.
Great. Well, so this is related to another question we got prior to the event from Jocelyn. You talked about the adult onset piece. She also asked, what's the likelihood genetically that one of my children will have ADHD if I have it and my father has it? And then at what age can or should you get a child evaluated for ADHD?
So there are different ways that conditions are inherited. So there's a classic, what we call Mendelian genetics, where it's a predictable autosomal recessive or autosomal dominant trait. And that's very predictable. You can give almost a percentage of what it will look like. With ADHD, there's a few more moving parts. So ethnicity plays a role. There's some other things that play a role. But I will tell you that by and large, when I find one person with ADHD, they know somebody in their family that's been diagnosed or should absolutely be diagnosed. I love when I see parents come in, the child will be diagnosed and treated, and things improve drastically for them. And then, dad will call back a couple months later and say, you know what, I see some, features in Junior that are, kind of common to me. Sometimes it's the other way around, where the parent has a diagnosis and they see that in their children. As far as diagnosing age goes, we will typically do around age 6. Sometimes we'll do a little earlier, depends on how impactful the symptoms are. In younger years, we focus more on cognitive therapy or behavioral therapy. We usually don't start medications until we see, for second grade in most cases. But again, there's outliers. But one of the reasons to diagnose early is the thought is the earlier the diagnosis, sometimes the more certain it is. And that can carry with them long term. For our own assessment, we are, of course, bound by HIPAA laws. And so we can't tell anybody, your kid even had an assessment, much less disclose the results. So, parents can take this and lock it away, and maybe they don't do anything with it during their K through 12 years. But when that kid's studying for the law school exam, or they're studying for a medical school exam or some professional exam, they can pull that diagnosis out and apply for extended testing time or other accommodations. So I think, even if you don't intend to treat, or you're on the fence to treating, I think earlier the better if there's a suspicion and you want to have the assessment done.
Well, related question she had was, how often does ADHD coincide with sensory processing disorder, or SPD?
That's not one that I see, tremendously often. When I see sensory things, I'm more, kind of poking my nose in the autism spectra area, because, that tends to be something that can be misdiagnosed as ADHD or run alongside ADHD as well. So I would say that's probably less of an issue. Now, having said that, sometimes what I would call coping mechanisms are decreased in our younger patients with ADHD. And so if it's just a true sensory issue, then it's going to be just those sight, sound, smells, and things that set them off. If every little thing sets them off, so the tag at the back of the shirt, but also their brother and everything else around them, that could absolutely be just an executive function or impulsivity issue. And that would steer me more in the direction of ADHD.
Great. Well, related to that, these just seem to kind of flow together.
Mm-hmm.
In the chat, we had a question from Mark, who asked, looking for recommendations for executive function based learning programs or schools for my teenage boy. Weekly executive function coaching is proving to be too little help.
I think some schools are stretched really thin. And so it really depends on, where you live and what the funding is like for that school. I recommend we first start with talking to teachers and administrators about what resources they have in the school. That's a good starting point. An IEP is something that we have patients apply for as well. Sometimes that will allow them to even bring in additional resources that aren't currently at the school. And that allows the school to have additional funding as well in some cases where they can apply for those resources to help your child. Um, Oftentimes we will leverage some outside help with this as well. So maybe not necessarily during the school day, but afterwards when we're working with homework, having some coaches helping with that. So outside resources can be helpful. I think a lot of it just has to do with what your budget is and what resources are available in your community. I know that we are looking to expand those services as well. You were not the only one to bring this up. We're moving very quickly to expand those services as well through telemedicine because most people don't have those experts in their community. They're just not available, and we have a pretty wide net of providers that we can partner with, and so we think we can do a good job of bringing those resources to those locations.
Great. Let me find, I just had one that I wanted to ask. Sorry, let's see. Let me cut to this one. This one's from Lynn. My college son took a detailed online assessment, but in order to be seen for treatment, the MD wants him to get another assessment. The place he called for that is requiring a referral from a medical doctor. The red tape is frustrating him, so he hasn't gotten any help. What's the best way to navigate all this? And how should a parent help or not help a 20-year-old do this?
This has got to be tremendously hard as a parent because you want to step in and help, but you almost feel locked out a little bit, don't you? Because once the kid turns 18, you can't be involved unless they invite you to be involved. Um, this was why we started ADHD Online. The history of this, I don't know if it's been widely published, but you know, I'm one of the co-founders, and this all started when I went out to lunch with a psychologist friend of mine who had his doctorate in psychology and was a known expert in the community. And I said, there's got to be a way to fix this problem because we have a 9 to 12 month waiting period to get people in to be assessed, and the cost was astronomically high. And that's how this started. So this story is very common. I wish it weren't, but it is. And so we would always be happy to help. I think if he's in college, another thing you could do is look into the student health services and ask if they have some availability where they can help as well. Sometimes the medical school campuses, if it's a larger university and they actually have an integrated medical school, will have a medical school clinic or campus where they also will see patients. Wait times there can be less for college students, so that would be an option as well. And then I would also maybe, I don't know if I would use the word pushback, but I would question, why do we need another assessment? Was it just ambiguous? It wasn't clear. Was there some specific information that needed to be clarified? Maybe it's as simple as reaching back out to that provider and saying, my doctor has some specific questions about your assessment that need to be answered. Would you feel comfortable making an addendum to your note or clarifying the information so they would accept that?
Great. Let's see. We had another one come into the chat from Abigail. She says, "Good evening. I got diagnosed with ADHD about a month ago. I'm a 20-year-old female. I have short-term memory loss, and sometimes I process what other people say wrong and have a lot of delayed hearing. Do you have any tips? I'm still trying to understand the full scope of this diagnosis. I have friends with ADHD, and sometimes even they would think I'm not listening."
That can be a tough one. So I would probably want to know a little bit more about why you have the short-term memory loss. Did you have a history of multiple concussions? Was there some kind of birth history we need to know about, or, other complications, in utero? And then I would look to see, what exactly is the memory issue. So I would probably start with, sometimes will involve neurology as well or neuropsychology to do some different testing than ADHD, specifically for memory issues, and see if we can nail something down there. I would look to organic causes as well because thyroid dysfunction can cause memory issues. We can also see this with depression. We can see it with sleep apnea. So there are a few things we would probably want to weed out. Having said that, it's always possible you have this separate attention, this separate memory issue. And then you also have ADHD. Now you can tell the difference a little bit in how ADHD is contributing to this, because most of the time the memory issues with ADHD is what I would call passive listening. And so, you're on autopilot, you're nodding, and you're not hearing anything. And so this is really famous where people that, spouses will say, I know you're on autopilot, you didn't hear me, here's a list, and so if it's that kind of thing that affects your memory, that would speak more to ADHD. If it's just in all scenarios, in all cases, you just have a just clearly defined short-term memory issue, then I think at that point, we would be looking at involving some other specialists as well in conjunction with what we do.
Great. Let's see, we've got another question from the Q&A. This one's from Hope. I'm an adult female that struggled with learning. Throughout school, I was labeled as a slow learner or lazy. As an adult, I still struggle with comprehension or completing lengthy or tedious tasks. Could this be a sign of ADHD?
Yeah, boy, that is so frustrating when we hear people say, your child is lazy, or they just aren't applying themselves, or not living up to their potential. That's such a terrible thing to say to a child. So I would really, first I would put the brakes on everything, and I would speak to that kid about self-esteem. Even adults would hear this, all the time. They'd hear, I was told I wasn't smart enough, or, I didn't apply myself in my younger years. I would, even be very purposeful about saying, that wasn't true. And I need to understand that was a lie that was told to me in the past. And then focus on some positive things that you can do for the ADHD. Look at some of the things that ADHD can do for you, instead of just all the negative things around it. We have a big picture, a big blown up picture of a dad and son, in superhero costumes with capes. And that's kind of our motto around here, because, we do feel it's a superpower. There's, in childhood, there's a swirl of distractions and things that are frustrating. And in the adult years, when properly managed, it's a swirl of brilliance and creativity and ideas. And so I would really encourage patients of all ages to filter out those negative kinds of comments and focus on the positive.
Great.
Boz, I saw an interesting question here too from Rebecca Starr. Can I jump on that one here?
Yeah,
too?
yeah, absolutely.
Yeah. So Rebecca put in and she said, my son, who's 9 years old, was ADHD, anxiety, and ODD when he was 6 years old. He's having a hard time with him wanting to try anything new or joining a sports team, just doesn't want to do it. Any tips for that? So, I would definitely get into that child's head about labels. And I would ask some very pointed questions about how do you see yourself? What do you see when you look in the mirror? What do you think other people think about you? What do your friends think about you? What do your teachers think about you? What do your coaches think about you? And if you're seeing a lot of negative things, that could be the roadblock. And I would really focus on those things individually, and have conversations with coaches and things, so that they're really encouraging of them doing it. Sometimes we just have to nudge kids a little bit out of their comfort zone and say, we really want you to do this team event. We think it's important that you do this, or you finish the commitment you made to your team. You want to do that. We also want to recognize that sometimes there can be some undiagnosed anxiety in childhood. And so the issue may not just be that we don't feel like it. There could be some serious anxiety related to that. God forbid, we always want to look for other things like bullying, abuse, other things like that. Ask some questions, around that. Do you just feel unsafe at those events? Did something happen at a prior sports team or in school or something? We want to dig through those things as well. And I would focus on some of the benefits of the sporting events and those other things, and say, when you exercise, you just feel better. Your heart rate gets going. It's easier to study later on. It's, you sleep better at night. Focus on some of those things as well.
Great. Let's see. We got another question in the Q&A that was anonymous. I got diagnosed with inattentive ADHD recently, and so I struggle heavily with focusing on boring but necessary tasks. I'm still working to find a medication that's right for me, but it's frustrating as I often tend to procrastinate and lose a lot of time. I've tried focusing music, keeping on a schedule, and even brute forcing myself to get things done. Is there any tips you'd have to keep focus?
I think the first thing is just you recognize that you have an issue. So that's really helpful. If you're comfortable disclosing the diagnosis to people close to you, you can say, you know what? Um, I need a list if you want me to do something. I need you to put it on my calendar because if it's not on my calendar, I won't be there. Those kinds of things can be helpful reminders. The other thing is you have to find a system that works for you. And so someone's system may be really awesome and complex for them, but it doesn't work for you. So I would say, you know, look into some organizational skills and look into some things like note taking. If you are in a situation where you have to listen for a sustained amount of times, say you're at a staff meeting or you're in a lecture or something, there's a difference between active learning and passive learning. Passive learning is I just listen and I try to absorb it. Active learning is I'm participating in some meaningful way, which means I'm taking some detailed notes and trying to, restate it in my own words to make sure I understand it. And then after I'm done with that, I'm going to go back and reread it and I'm going to, try to lock that in. Those kinds of things can be helpful. Sometimes if you have the opportunity, getting a copy of what's going to be talked about can be very helpful also because the brain, once it starts to become overwhelmed, the natural reaction is to just disengage from that. So if I'm learning about a really complicated topic, I've never heard anything about it, I'm feeling lost, and I already have ADHD, forget it. You're not going to pay attention. So if you can get some of those copies of notes or materials ahead of time to pre-read, that can be tremendously helpful. There are some great apps out there for project management. So, some of the just ones that come with computers are fine. Like, I use Apple and it has a reminders list. That's fine. But there are some free project management tools out there that are far more robust where you can link emails and files and you can prioritize things, put timelines on and goals. Those are very, very helpful for people with ADHD. And the last thing is, you mentioned the brute force, but how you do the brute force it matters. If you have someone with ADHD and you tell them you're going to study for 4 hours, forget it. It's not going to happen. Maybe it'd be better to say, I'm going to do brute force in 15 to 20-minute increments. Or maybe you're a college kid and you say, okay, I'm going to study this subject for 15 minutes. Then I'm going to jump over here and do this one. And I'm going to jump over here and do this one. That can be more effective than just reading the same thing for an hour, because let's be honest, you're going to remember the beginning, you remember the end, and you're not going to remember anything from the middle. And then the other part of the brute force thing is take things apart into the smallest increments possible. Again, if we feel overwhelmed, we won't complete the task. So if I say I'm going to paint the whole house, that's going to be overwhelming. I may not get it done. But if I say I'm going to paint this wall of this room today, and then I'm going to get to it, the other wall this afternoon, maybe I'll do that. It would be easier for me. So break apart your projects into more bite-sized pieces, reasonable goals, and be comfortable taking breaks and skipping around from thing to thing, if that is easier to hold your focus.
That's a really great point, Randy. I've often heard, if you give yourself a time, double or triple it just to play it safe, just so if you get it done faster, you feel better, right? Than if you're.
Yeah. It's really funny with time management. You bring that up because if you ask an ADHDer, and I'm one myself, so I can admit it, if you ask us how long it takes to do something, we're going to get it wrong every single time. Because in my mind, I'm like, okay, I'm going to bang through that. And I'm going to get all this done. And it's going to be a lot shorter than the time it actually takes. Travel time is another thing as well. I have an amazing executive assistant who manages my schedule right down to travel time. And she knows to have everything on my calendar and she manages it well. That is really, really important, is to be realistic about times and how long each thing takes and not overwhelm yourself with an overly busy schedule.
Great. We had another question come in. Is our primary care physician the best place to start when getting diagnosed?
So primary care doctors usually will not make a diagnosis of ADHD. They're going to refer you to a psychologist. And if your community has access to a lot of psychologists, then it's not an issue. Most places do not have great access. There's a lot of delays. Sometimes they'll get backed into a corner and we see a patient in crisis and we'll treat them. But then there's always this desire to have them circle back and have a formal assessment at some point in time. That's just for the medication management side. If you're looking for things like workplace accommodations, IEPs, extended testing time for professional exams, they're going to want a formal diagnosis by someone who really knows what they're doing. So, I guess you can feel them out and see what resources are available and start there. But if you're hoping to get the diagnosis and the medication all in the same visit from your PCP, you'll probably be disappointed.
Great. Let's see. We've got another question that I've heard before, so I think it'd be a good one for a lot of people. Jasmine has said, I'm a 32-year-old female recently diagnosed. As expected, I've been having trouble sleeping as my doctor tries to find the right medicine and dosage. However, I've been resistant to sleep aids as I don't want to become medication dependent. In doing so, I'm finding that when I quote unquote sleep, it's as if I'm not sleeping, but also not awake, as sort of in between state. Therefore, I wake up exhausted. Is that normal? And do you advise I take sleep aids to get adequate rest? And if so, any suggestions?
Another great question. Yeah. So one thing is, if we're treating with a stimulant medication and you feel like it's lasting too long into the evenings, you notice a sudden change in your sleep patterns with the addition of the medication, then we look for medication side effects as the cause, and we may make some adjustments there. Um, if we don't see a sharp correlation there, then that could be a separate sleep issue, and that really should be addressed properly, because non-restorative sleep can absolutely affect attention, and so we should be looking into that. The one that everyone knows about is obstructive sleep apnea. That's the neighbor you can hear snoring next door, but there are other sleep issues as well that can cause non-restorative sleep, like central sleep apnea, where you just stop breathing, you just have apneic episodes and oxygen levels plummet. There are other things that you wouldn't even think would affect sleep, like reflux. So if you had really uncontrolled reflux and throat clearing and hoarseness and cough and things after you eat spicy foods, when you lay flat, your body will continuously guard that airway, and you'll startle awake over and over and over and never hit a REM cycle. So that'll be non-restorative sleep as well. You're also describing what we call like a twilight. So this is almost this transition into an actual, fully being asleep. And so some patients will have separate sleep issues altogether, where we need to do an EEG. We need to see what the actual sleep patterns look like and see, if there is some other underlying sleep issue. Restless legs, another one that can cause this. There is a separate sleep condition called periodic limb movement disorders, where people will just move their legs in their sleep, or, if you're acting things out in your sleep, you're running from the tiger in your sleep. That's something that could signify a larger issue as well. One other thing typical of ADHD, aside from just, the medication side effects, but just ADHDers and sleep in general, is, we always have this feeling like we're forgetting something, right? Or this amazing idea comes up and we're going to forget it. So what I tell patients to do is keep a journal next to their bed and write it down, right? I got, this thing with the dog. I got to take the dog to the vet this Friday. I forgot about that. Write it down and you can go back to sleep, because you're not going to forget it now. That brilliant idea, write it down and you can go back to sleep. Those little things can be really, really helpful as well. But if there's any question at all about the underlying cause, go ahead and get a formal sleep study, not a home one. Those are just sort of worthless, if I'm being honest. Get a formal sleep study by someone who knows what they're doing, board certified in sleep medicine.
As a sleep apnea sufferer, I can attest to the value, so wholeheartedly agree. Another question that came in the Q&A, and I just want to set expectations now because it's 7:53. We've gotten a number of questions, and so just want to let everyone know we won't have time to get through them all tonight. Claudia and I, who are both on the webinar, will be working to get answers or responses to everyone that's come in, and if we can't get them to you soon, we'll get them to you as quick as we can. But we really appreciate all the participation. So, Randy, we got a question from Michael. Is there a law of diminishing return on the daily use of ADHD medication? Is it recommended to take breaks to prevent needing to increase doses?
I don't think there's ever been any really, significantly demonstrated study that it would tell you for sure that has to happen. I think I've known patients that have been on the same dose for years and years and years and years. And so I don't think that there really is any effect there, unless we're talking about a child that's aging. So, they're they're getting older, that we would expect a dose from that. If we're being placed on different medications, that can affect the dose as well. So sometimes we do have to do some fine tuning, but it's perfectly reasonable to think that someone could be on the same dose of medication for years and it be just as effective. Um, so no, I'm totally comfortable maintaining a dose in a stable patient.
Great. Let's see, another question from the chat from Jenna. Should I only take my medication for school like my doctor suggested, or should I use it day to day? I've been using it less, but I notice I function better when I'm on it.
It depends who you ask. I think a lot of psychiatrists will tell you that ADHD is a 24/7 condition and you should be treating it all the time. I personally disagree with that. I think that what makes the difference between a good doctor and a great doctor is recognizing each individual person's needs. We are not all the same. We're not cookie cutter. We all have different needs, goals, challenges. And so I tailor the regimen to their needs. And so if you have classes that are more difficult or things that are more difficult and you need to take the meds on those days, great. On the other days, then go ahead and not take it. There is a fine line as far as dosing goes where you could run into some withdrawal issues if you went from, a really high dose of med, then you stopped all of a sudden. And to be clear, we're talking about stimulants here, not the non-stimulants. We're talking about stimulants. So you would want to make sure you weren't on such a high dose that was an issue. There are some really long-acting ones we can use if that's a problem, like Mydayis. There's also an alternative drug like Jornay that it absorbs differently through the small intestine rather than the gut. So sometimes we'll capitalize on that to get the right, the drug in at the right time. But no, I think tailoring the care is extremely important to patients, and I fully support it.
Great. I saw another question in the chat that's somewhat related. And it feels like the type of thing that you and I have talked about. So Dylan asked, I'm often nervous when talking about my stimulant meds with my doctor due to the negative stigma surrounding it. Is this all in my head, or how do you best advise I approach talking about my medications so I don't feel, to put it frankly, like a drug addict?
Oh, boy, that just is so disappointing for me to hear that, to be honest. And I'm sorry that you feel that way, because honestly, I tell my patients, if you ever feel like you're not being advocated for, if I'm not cheering for you, if you don't feel like I'm your partner in your healthcare, then please don't leave the office, because we have to have a conversation. I think that some doctors are not comfortable managing ADHD. And I think, unfortunately, lack of understanding can sometimes translate into judgment or other negative feelings. I also tell patients that choosing a doctor is like dating. You don't owe anyone an explanation why you stay with someone or why you don't. And I never take offense. Pride has no place in medicine. And so if you feel like you're not getting the care you need, feel free to, either look for another doctor or reach out to a specialist. We have a lot of patients that still see their primary care doctor they have a great relationship with, and we manage their ADHD meds, and nobody's upset by that. So that might be a starting point too, to say, can I have a specialist or, an expert in ADHD manage my medications and take that off your plate. I would also say, and I hope that if there are parents listening out there with kids, they would bring them in for this part right here, because we need to do a better job about talking about mental health. And if you're struggling with mental health out there, I'm going to look you right in the eye and I want you to hear me. You are not broken. This is just a medical condition. It's all brain chemistry. It's treatable. It's manageable. The goal is not to make you normal. I've been a doctor for years. I've never met a normal person. I don't even know what that means. And so the goal is to make your life better, make you more functional, make you more successful, make things easier for you, but not under any circumstances to shove you into a box that we label normal. And so, a lot of people that are very successful have ADHD. I've never met an ER doctor that didn't have ADHD. Most attorneys have ADHD. A lot of CEOs have ADHD. A lot of public speakers have ADHD. Google it. There's a lot of people out there that kind of come out about it, and it'll surprise you. But, I really hate the D in ADHD. I think it's a blessing in a lot of ways. I attribute a lot of my success to ADHD. And so our goal here at ADHD Online is to offer some clarity, to offer education, to offer support, to offer treatment in a positive way that meets goals, rather than tries to ward off other people's negative feelings and opinions. We try to forgive people for their ignorance, but it can be hurtful sometimes. We want this to be a refuge of support and understanding for our patients. And so it's very important you surround yourself by people that care about you, that support you, that accept you for who you are. That includes friends and absolutely includes your healthcare providers.
Great. Well, it's gone by fast, but we're at the hour. And from the number of questions that we didn't get answered, it's clear the demand is there for more of these. I think it's very encouraging to us here at ADHD Online to see the interest in these topics. And we look forward to getting into more specialized topics, but also, just continuing to be an ongoing resource to the community to answer frank questions like we did tonight. So Dr. Duthler, thank you so much for taking the time tonight. Again, everyone that we didn't get to, thank you so much for participating and asking your questions. We will be following up with you. And please do stay in touch with us. We're on social media. Look for our newsletter and our blog. And we will see you again soon.
All right. Take care, everybody.
Thanks.